Okay, it's 10:18. I just spent the last 7 minutes talking and not recording, so I get to start over again. That's really fun. It's this chapter 20. I don't think I'm going to make it all the way through. If I do, I'll have to pause, do a little more notes, and then do the end of the chapter, which is really adrenal glands, which I kind of wanted to get to. But if it's okay, I'll just do it tomorrow. Tomorrow and or the next day or the weekend, I'll be getting onto the neonate brain, which is pretty cool. Those are cool to do. And last place I was doing neonate brains, the babies were so premature, their heads were about the size of, now bigger than ping pong balls, but not much bigger. And so my transducer was actually bigger than their entire head. But today, pediatric kidneys. And I am recording. Sorry guys, I got to double check. Pause. Okay, yes. Okay, share the screen. Not any good if I don't share the screen. Okay. So pediatric kidneys can look different. Neonates, especially the premature neonate, can have a relatively echogenic cortex. So I've drawn a liver here, and I've purposely drawn the liver parenchyma darker, more hypoechoic than the kidney parenchyma. This is the cortex. Remember, cortex technically is from here to here is the cortex. Down here are the columns of Bertin. It's all parenchyma, but column of Bertin reaches down. Anyway, so this is normal. We got a picture over here. This is a normal neonate. Neonate, in other words, newborn. Especially premature, they can look like this, echogenic compared to the liver. If this were an adult, a young adult, older adult, I would be concerned, and it would be most likely a concern of the kidney. This looks, if I didn't know better, if I didn't know that I was looking at a neonate, I would say, uh-oh, renal parenchymal disease of some kind. But this is okay in the bye-bye. And in fact, their pyramids can be so prominent as to make you think they're cysts. Now, we don't really see that in this picture here, but the pyramids can actually look like cysts. Now, if you see kids all the time, you're not going to make that mistake. If you see kids once in a while, and kids, kids, younger kids, not necessarily neonates, but younger kids can have very hypoechoic pyramids, and I'll just say, not cysts. Not cysts. And it could be also, I drew this one large over here. The book does mention that there are things that we could notice in the young child that we wouldn't simply notice in the adult. In the adult, if there were kind of a double-sized or a little bit malformed pyramid, we probably wouldn't even notice it because we don't see the pyramids that clearly. But in the child, we would see it. And so sometimes, yeah, these pyramids can fuse into one mega pyramid. And so don't be too flipped out by that. Fetal lobulations are normal and expected. So I've purposely drawn this kidney a little bit lobular. This is okay. It's actually okay in the adult too. It's just that we don't see it very often because we usually grow out of it. Usually, not all the time, but usually. So lobulations are normal. The sinus or pelvis may be entirely fat-free, so not echogenic. And I've kind of drawn the pelvis in here as black, and that might not be entirely accurate, but these guys can be very hard to see. And if you look at this kidney here, where's the echogenic hilum? Where's the center of that kidney? It's not really shown. It's not because we're off to the side of the kidney where you're only in the parenchyma. We're actually right down the middle of that kidney, and we don't even see the echogenic sinus because it's, well, not echogenic. The length measurement in length measurement is always important on a kidney. Length tells you health. Atrophic kidneys, or kidneys that are dying, they quickly reduce their length. A kidney that is extra long might be an indication of compensatory hypertrophy. That kidney is doing all the work for some reason. Maybe the other kidney has died, or it could be because of a diffuse disease process making the entire kidney enlarged, or it could be kind of a double kidney where almost like two kidneys fuse together on one side. But in the child, it's very, very important to get this measurement correctly. By the way, when we see children, we have to be somewhat inventive on how we see the child. Babies, I'll oftentimes have mom lay down on the bed and the baby lay down on top of mom. Very comforting. Baby could actually lay face down on mom's belly. Very comfortable for the baby. And then that way I could scan through the back in the prone position. A little bit older children, they might not be into that, but definitely mom or dad in the room is always helpful. Computer's making all sorts of sounds. Okay, so length, very, very important. There are charts. If you are a location that sees pediatrics, there will be a chart posted somewhere at your facility. Because the charts say, okay, 3-year-old's kidney should be, I'm guessing, 6 centimeters. Less than, or thereabouts 6 centimeters. And, more than 2 standard deviations below that or above that, there's a problem. Charts give the age of the child and expected length. In case of the newborn, prematurity is actually built into the chart. So obviously, a premature baby is going to have a smaller kidney than a full-term baby. I mentioned agenesis. I don't even know why, but because bilateral agenesis is not compatible with life. You cannot survive. You can survive in utero without kidneys because mom does all the work for you. But as soon as you're born, unfortunately, you are, and it's not so much renal failure, it's the failure to be able to breathe or anything, which we'll talk about next semester. Unilateral agenesis, well, then you just have one kidney. And the other kidney is probably larger than normal because of compensatory hypertrophy, of course. Reasons for agenesis, well, it could just be idiopathic. We don't know why. It could be multicystic dysplastic, which is later on in this lecture where we basically destroy one kidney through obstruction. Could be a vascular accident where vascular, it was the artery either didn't form or got clogged, obstructed. And the kidney died early on in development. It just never developed. Hydronephrosis, mild cases are not uncommon in the baby. A lot of times it's just a simple UPJ obstruction, a little kink in the ureter as it leaves the pelvis. That's the most common structural cause of hydronephrosis. And so this first image, I don't know how old these individuals are. I didn't necessarily, I asked for pediatric imaging and it gives me everything. On this one, this is very mild hydronephrosis. This is not causing kidney damage, thankfully. I would say the next one's probably not causing kidney damage, although over a very long amount of time, it perhaps could cause a little bit. Here, we're skating on kidney damage, and here, well, obviously, there's barely any normal kidney left. This poor cortex has been squeezed completely out. Mild cases are not uncommon. The worst case, the bad cases are a little more uncommon, thank God. Oh, I'm sorry, and let's remind us what UPJ, ureteral pelvic junction obstruction. So this is your, let's use this guy. Let's see, draw a quick kidney, ureter, and then it opens up again. And so UPJ, here's our little cortex of the kidney there, or I'm sorry, sinus cortex on the outside. That would be like a UPJ. So no hydroureter because it really happens very close to the exit of the kidney. UVJ, ureteral vesicle. Remember, our bladder is considered a vesicle. UVJ, so ureteral vesicle junction obstruction. This can be caused by a ureteral seal. So in a child, we don't see stones getting stuck in the UVJ too often. More likely a ureteral seal. And remember, that is as your ureter comes down into the bladder, comes underneath the bladder. Here's my bladder here. There's my bladder. And if there is a obstruction of membranous obstruction, that can cause a outpouching of that obstruction. And if the obstruction probably has tiny little hole in it, it allows urine to come out, but still that causes urine backup, so a reflux of urine because of this unnatural, unwanted little bubble of tissue at the end of the ureter. Could just be regular reflux. Baby has another defect here, and so urine reflux is back. It can cause megaureter. Megaureter being a ureter, instead of being that sized, is now, well, let's draw a giant ureter. This is a megaureter. Megaureters, very likely, will go back to cause a significant fluid buildup in the kidney, significant hydronephrosis. Another cause of megaureter actually is just a lack of peristalsis. So the muscles in the wall of the ureter, just like we had yesterday or day before, megacolon. Lack of peristalsis in the colon causes it to expand because feces gets impacted in there on a daily, weekly, monthly basis. Megaureter is the same thing. Urine kind of drips in but doesn't really get forced into the bladder, and so the ureter itself actually almost acts as a bladder, as a reservoir for urine. If you have bilateral hydronephrosis, bilateral, not necessarily megaureter, but just hydroureter. Here's the term right here, hydroureter. Oh, let me do something really quickly with my learning different tricks here. Okay, now it's all one level. If bilateral, then it's more likely that the urethra is obstructed, or there's something causing a bilateral obstruction. It could be a giant mass causing bilateral obstruction, but perhaps the urethra is not working correctly. Just over here, great image, hydroureter. Not necessarily megaureter, it's not that big, but it is a hydroureter, and significant hydronephrosis at the same time. So we don't want to see that. Posterior urethral valves. This is kind of an OBGYN type of thing. So next semester we'll talk about this again. But we mention it now, and yes, we can see it after birth, so I guess we'll talk about it now. Posterior urethral valves, PUV. This happens in boys. It actually happens in a valve. I put in quotation marks. So it's not really a valve. It's really just a membranous obstruction. Membranous obstruction in the prostatic urethra. So unless a woman has a prostate, she is not going to have this problem. But that obstruction causes the bladder to increase in size, and really bad cases, the bladder can become enormous and could actually rupture in utero. And the ureters, of course, they could be increased in size, so hydroureter, megaureter is possible. Kidneys, hydro, that's a plus sign, plus damage if it's really bad hydronephrosis, which probably is. Extreme form in utero can lead to prune belly syndrome. It's called prune belly syndrome, by the way, is because when these babies are born, their belly is like a wrinkly old prune. And here's a little belly button right there. It's all wrinkled and everything because they were so stretched out. And prune belly syndrome, there's a lack of musculature in the anterior abdominal wall. Well, the muscles were not able to form because of the intense stretching. These babies in utero, I should have grabbed a picture, but let's just do a quick, really horrible image of a head, back, little legs going off here, and then a belly like this. And inside that belly is just all urinary bladder. So this is a sad, that's a sad child, because this urinary bladder is just absolutely filling the belly, stretching out the skin, stretching out where the muscles would normally be forming, and so those will not form. He's sad because he'll never win a sit-up contest. God, that was mean, but it's true. Something wrong with me. Anyway, next one, multicystic dysplastic kidneys, MCDK. This occurs with complete obstruction of the kidney in utero. So in development, there's a urinary obstruction. This happens pretty typically early in utero, not late utero, but more early. And the kidney is completely replaced by cysts because the kidney continues to produce urine. And by the way, fetal urine is pretty much pure water. It's not anything like adult urine or child's urine. It's water. But this kidney is replaced by cysts because it continues to produce urine, but has nowhere to go, and it backs up. And so this is a multicystic dysplastic kidney here, and you can see that the kidney is basically completely replaced with cysts. You may have this. Well, you probably don't, because I think I've seen all your kidneys. Actually, no, that's possible. And so, but anyway, the long story short is adults can have a unilateral multicystic dysplastic and never know it because they didn't have, especially if you're an older adult, if you didn't have ultrasounds during pregnancy, this was not seen during pregnancy. In the adult, these cysts generally go away and you're left with basically nothing, no kidney on left or the right side. If it is bilateral, of course, you now basically, in effect, have bilateral agenesis of the kidney. It is not compatible with life. So there's no such thing as an adult with bilateral multicystic dysplastic kidneys. Infantile polycystic kidney disease, or also known as autosomal recessive polycystic kidney disease. So ARPKD. With this one, we also have cysts, but they are countless and microscopic cysts, usually too small to resolve, which be microscopic, but they're very small cysts. And what happens, well, I've talked about this before, when you have many, many tiny cysts or many, many tiny ectatic tubules, in the case of medullary sponge kidney. Even though these are fluid-filled, and we normally consider fluid-filled cysts to be quite hypoechoic with through transmission and all of that, when they're very, very small, it just creates thousands and thousands and thousands of interfaces, each creating an echo. So just so many echoes are coming from this that we end up not seeing the fluid at all. In like the typical fluid, which is hypoechoic. So we end up seeing an echogenic pattern. So these kidneys are large, they are echogenic. Liver involvement is 100%. So this disease does not affect only the kidney, it affects the liver as well. But this leads to fibrosis of the liver. So these people will eventually have renal and or liver failure, unfortunately. So they need medical intervention, new kidneys, perhaps a new liver. And I've seen both, but in utero, I've seen both. I've seen adult polycystic kidney disease in utero. We normally don't think of this as occurring until a little bit later in life. And certainly most people who have adult polycystic kidney disease, or many of them anyway, they don't even know it until their late 30s, early 40s, when finally their kidneys start to fail. And then they do an ultrasound. It's like, oh my God, how did you not know this? You have cysts everywhere. But in the child, this is also called autosomal dominant. The other one was recessive. This is dominant polycystic kidney disease. So this is ADPKD. In the child, this can look a lot like ARPKD because the cysts are still very small. And this is what I saw. This is when I saw adult polycystic kidney disease in a young woman who was pregnant. You know, she had a known case of ADPKD, and I thought, okay, well, good. It's adult polycystic kidney disease. I'm not going to see anything. And sure enough, I did. Clearly saw that her fetus's kidneys were abnormal, and they looked like the other ones, honestly. But here's a young child with adult polycystic kidney disease. And so some are big enough to see, obviously, but there's a feeling when I look at this image, I could see that, boy, this seems like a long kidney. Seems like it anyway, perhaps it's not. Not exactly echogenic, it is isoechoic with the liver. Feels like a large kidney, but without more imaging and measurements, I don't know for sure. All right, can't look like it. There were some other cystic diseases. I decided to just kind of lump them together, guys. Do read your book. Other cystic diseases of the pediatric kidney are usually associated with genetic syndromes and diseases like Zellweger syndrome or tuberous sclerosis. Boy, in your book, there's a complete cystic degeneration of the kidneys with a young person with tuberous sclerosis, which it's actually new to me. I did not know that that can happen. So that's a new one. Turner syndrome, that's something that's, these are females only. The males with Turner syndrome cannot survive, but the females do survive. Von Hippel-Lindau disease, we've seen that a few times. That does cause cysts in many organs, and et cetera, et cetera, et cetera. There's always something going on. In other words, in the child, a simple, phone scared the hell out of me. Simple cyst without anything else going on is actually rare. We get simple cyst in the adult, not rare, but in the child, it is rare. Wilms tumor. This is kind of like one of the big, like the top 5 pediatric tumors, you know, overall diseases of pediatrics. So this is an important one to know. Wilms tumor, the most common malignant renal tumor in young children. It's also known as, AKA, nephroblastoma. Nephroblastoma. Often spontaneous, in other words, no known associations or anything with it, but Wilms tumors can be associated with Beckwith-Weidman. I said, you know, I mentioned this yesterday. I thought it was Wiedemann with an R, but it's not. It's Weidman syndrome. That is basically organ overgrowth. There's some specific things that go with that, but we'll talk about that next semester. But basically, large organs, hemihypertrophy. Similar, not similar, but there's kind of an underlying similarity between Beckwith-Weidman and hemihypertrophy. Hemihypertrophy is half the body is increased in size. So you can see that there's growth issues, or overgrowth issues are associated with Wilms tumor. So hemihypertrophy, literally half the body is larger than the other half of the body. I knew a doctor like that, and it was pretty remarkable to look at him. I mean, his let's see, I think it was his right leg was shorter than his left leg. His right arm shorter than his left. His entire torso was slightly different size. His face even, I think his face was even slightly askew, like his left side of his face was actually larger than the right side of his face. So everything was, and I mean, it's not like huge difference, but you could see it if you took this time to look at it. In any case, I'll tell you a little story about hemihypertrophy. I was very well respected in the OBGYN community back in Colorado. And I always prided myself on doing a great job, and doctors really liked me. But I tell you what, I did miss this once. And the doctor wasn't at all mad. He says, Kurt, he says, you know, who's going to catch that? But basically, I missed hemihypertrophy. And now this child, because he had hemihypertrophy, he had to go back to yearly, maybe even every 6 months, have an ultrasound of the kidneys to make sure that this tumor did not occur. Because people with hemihypertrophy and Beckwith-Weidman actually have very high incidences of Wilms tumor. But because I missed this one time, I now always measure both legs. Most sonographers will measure one femur. I measure both because of missing that one time. Aniridia is interesting. That is someone who does not have a iris. So they have just one big black pupil, and it's terrifying to look at. But that is also Tumor is typically large at presentation. In other words, it's painless. We don't really know that the tumor is there until there's a noticeable lump or a noticeable renal issue, perhaps. And then by the time by the time the doctors see it, it's quite large. It tends to be well encapsulated, or well circumscribed is another term for that. Mostly homogeneous, but the book said homogeneous. I'm saying mostly homogeneous because the book also spoke out of the other side of his mouth and said there's hypoechoic structures inside of it. Well, that's not homogeneous. Can metastasize to nodes, liver, and lung. So if you see lymph nodes around the aorta and IVC increased in size, it very well could be, in a child, it could be Wilms tumor. It can invade the renal veins. So that's the easiest way for it to travel outward. And so it will find the vein. It goes through the vein, maybe into the IVC and up towards the heart. So here's a uniformly solid Wilms tumor. You can see there's some normal kidney around the outside of it, but it's a well circumscribed tumor, decent size. This one appears, I don't know if it's bigger or not, but this one, of course, has a bunch of cystic spaces in there, so you can't really call it homogeneous, can we? And these cystic spaces, these could actually be captured medullary pyramids. This one could be a pyramid. And then this one looks as dead center, perhaps that is necrosis of the center of the tumor. Nephroblastoma,tosis, I didn't bother creating its own little grouping on this one. It's basically a benign form of nephroblastoma, or Wilms tumor. It's a benign form, but is also a precursor to Wilms. And so it doesn't mean if you have a child with nephroblastoma,tosis, it doesn't mean they're going to be Wilms tumor, but they very well can become a Wilms tumor. And they have a couple of different presentations. It could be seen as hypoechoic masses within the columns of Bertin, or more diffuse all over the kidney, hypoechoic kidney, enlarged kidney. Just make sure the most common malignant renal, most common malignant renal tumor is Wilms tumor. But the most common benign tumor and the most common abdominal tumor overall is mesoblastic nephroma. Now that's going to look a lot like a Wilms tumor. So, bam, there you go. Well circumscribed tumor, mostly homogeneous tumor. There's a few things going on inside of it. It's a pretty homogeneous looking thing there. The good news is it's benign. The bad news is it has malignant potential, so this can become cancer. It will be removed. It'll also be removed because it can take over the entire kidney and just continue to grow. And so eventually, even a benign tumor can kill you if it gets big enough or if it's well enough placed to cause problems. Medullary sponge kidney, tiny cystic dilatation of the pyramids, collecting system. So just like I was saying before, I was saying all these tiny little cysts, even though they're fluid filled, can look echogenic. That's what happens in a medullary sponge kidney, except that rather than cysts, it's the collecting system causing almost like little dilatations in the collecting system. But thousands upon thousands of them in very small space can cause an echogenic collecting system. In other words, the medullary pyramid. instead of being hypoechoic, is echogenic with medullary sponge kidney. We talked about this already, but figured it was worth mentioning again. Nephrocalcinosis. One reason to get nephrocalcinosis is medullary sponge kidney, and what happens there is that urine simply gets stuck. There's urinary stasis. Urine stays in here over a period of time. Calcium, what's the term, precipitates out of the urine and can cause calcium to build up on the walls or to cause thousands upon thousands of tiny little sand calcium type precipitate. Nephrocalcinosis can also be caused not necessarily by medullary sponge, by any kind of hyperparathyroid. Remember that parathyroids, when they are increased in function, you have too much calcium. You have hypercalcemia, or perhaps you have nephrocalcinosis because there's some kind of tubular reabsorption defect. The urachus, we've talked about this, so I didn't write anything down, but I did grab a picture. Remember the urachus in development, our bladder was open through the outside of the body, basically through what's now the belly button, along with the umbilical cord coming in and going in the belly button as well. Incomplete fusion of the urachal, I don't want to say tube, the urachus, we'll just say incomplete fusion here, remember, can allow cysts to form, like a cyst perhaps underneath the belly button. These can become infected, they can bleed, that's bad. You could even have a completely open urachus, which is actually shown right here in this patient, is a patent, in other words, open urachus. That is something, and by the way, you should not be looking at this without a, well, you could look at it, but always, generally with pediatrics anyway, but certainly with this exam, go find your radiologist first before letting the patient go, because they might want to come in and see for themselves. UTIs, cystitis. You know, that's the other thing. A bladder can be called a bladder, which makes sense, or the vesicula. It could also be called, in terminology referring to the bladder, it can be called a cyst. In this case, cystitis refers to an itis, or an inflammation of the bladder. And then I mentioned earlier, what did I mention? Vesicle. A vesicle is, gosh, what's that, like ancient Greek for something that holds water, you know, a vesicle. So vesicle, cyst, bladder, vesicula, all mean bladder. So, and on this patient, we don't see anything in the bladder other than just pure urine. That's good, but this does seem to be a rather thick wall, a thick, remember the muscle? Detrusor with 2 S's, detrusor muscle. That's one word, detrusor muscle. I don't know. Spelling's not my thing. You guys know that. And the other thing we can possibly see with cystitis is debris in the bladder. You know, it could be dependent debris like pus, red blood cells. It could be bleeding. There could be white blood cells. Could be a combination of everything, all in that bladder as well. Okay, let's see. 11 o'clock. and I need to be out the door by 11:30. As you can see, I did not finish my adrenal gland, and I am hungry. So if I'm going to eat and make it to lab on time, I am going to have to finish here. Guys, any questions you have, remember I set up a forum. I don't know what it looks like at your end. I'm going to stop sharing so you can see my beautiful face here. Let's stop share. I don't know what the forum looks like at your end. Mine, I have to go into course tools in order to even find it. And then let me look at that again. Maybe I could have a link somewhere a little more easy, like right in your announcements or something, or right there in course content. I'm not sure. But anyway, as of right now, go on the course tools, find your forum, and ask me questions. Go ahead, ask questions with a little bit of paint. Anything that I've gone over, that I've gone too fast, if you feel like I didn't give enough information on something in the book that you didn't understand, let me know. Oh shoot, I didn't pull any videos today. I have time to pull. I'll pull one video and I'll post that, and you'll see that. So, all right, we will. My controls have moved. All right, guys, we shall see half of you today.